This is not connected. I'm getting juice here.
Is this, oh, this is on. The Sure thing has its own batteries, or is it just like a?
It's automatically
Okay.
powered, yeah. No, this is not connected. There we go. Here's that, okay. So now we just need this to light up for some reason. Okay, it's not try replacing maybe this cord.
Like this one?
Yeah, take that out maybe. Try that.
Oh, there we go. So this one's not working.
Okay, so we see how it's on like two lights right
So
now?
that's, we're good right there.
Yeah.
Test, test, test 1, 2, 3. Test 1, 2, 3. Test 1, 2, 3. Sounds good.
Okay.
Okay.
So now what we do is we'll hit these little like 3 dots. Yeah.
Good afternoon, and thank you all for joining the briefing today. As we move into the fall, from a public health perspective, this is also the time of year when we're likely to see an increase in illness and viruses. Today, I'll talk about what we're seeing right now in LA County with COVID-19 and other respiratory illnesses, and what can be done as a community to prepare. I'll take the next slide. You good, Brett? As we share every week, this slide shows updated trend lines for cases, hospital admissions, and deaths in LA County. In this figure, the green trend line shows the 7-day average of the number of cases reported daily, and it's measured using the vertical axis on the left. During the past week, an average of 1,300 cases were reported per day. That's a 24% increase from the 7-day average of slightly over 1,000 cases reported per day last week. Average cases reached a low point of 870 cases a day on October 16th. As you'll remember, we plateaued, and as you can see here, for the rest of October. But we've really been slowly but steadily increasing since November 1st. While reported cases represent only a portion of those infected, we still pay attention to this trend line, as it fairly accurately captures changes in transmission. As expected with rising case counts, we're also seeing an increase in the average daily number of hospital admissions. That's on the orange line. This past week, there was an average of 77 admissions per day. That also an 18% increase from 65 admissions per day last week. The blue line on the slide is the 7-day average number of deaths reported daily, and it's measured by the axis on the right. We're currently reporting an average of 7 deaths per day. This is slightly lower than the average of 10 to 12 deaths we reported earlier in the month. However, since deaths are always a lagging indicator, we're concerned that if we continue to see increases in the case and hospitalization numbers, then our deaths could rise a few weeks from now, as they have in the past. These case, hospitalization, and death numbers highlight how many people across the area are still experiencing the impact of COVID-19, including losing loved ones. I'd like to offer my condolences to those who've experienced loss, and I hope you find comfort and healing. Next slide. Using the CDC's community levels framework, LA County continues to remain in the low community level. With this being said, we've seen increases across all 3 indicators this past week. Our case rate is now 86 new cases per 100,000 individuals. This is up from 65 cases per 100,000 2 weeks ago. If the case rate rises to greater than 100, in accordance with the LA County COVID response plan, indoor masking will, as it has in the past during times of elevated transmission, be strongly recommended for everyone. Currently, indoor masking is based on a person's individual preference unless it's required by a site. Both hospitalization metrics also slightly increased this week. The admission rate increased from 4.4 admissions per 100,000 people to almost 5 new admissions per 100,000 people, and the proportion of staffed inpatient beds occupied by COVID patients increased a little bit from 1.9% to 2.5%. But although we're reporting these increases, I do want to note that both metrics remain well below the threshold that would move LA County to the medium community level. Next slide. We do have our 8 early alert signals that we consistently monitor to better understand potential changes in COVID-19 transmission. 3 metrics this week are of medium concern: the percent of new strains of interest circulating, the percent of emergency visits for COVID, and the number of outbreaks in school classrooms. I do want to note that given the many mutations of Omicron subvariants, we update our dashboard every couple of months to track newly emerging strains identified by CDC to be of possible concern. So starting this week, we're tracking 2 new sublineages, BQ.1 and BQ.1.1. These are sublineages of BA.5, and they currently account for 17% of our sequence specimens. The rapid increase in circulation of these strains is of concern, and I'll go into greater details about variants on the next slide. The 7-day average for percent of emergency department encounters classified as COVID-19 related also increased to 5%, So that's moved into being of medium concern. With multiple respiratory illnesses currently at high levels, we do want to stay aware of any increases in COVID cases that can contribute to strain on the healthcare system. In the TK through grade 12 school classrooms, you can see the small increase in the number of newly opened outbreaks, up from 9 last week to 14 this week, and that also moved this metric to medium concern. Unfortunately, after being at medium concern for multiple weeks, the number of new outbreaks in skilled nursing facilities these past 7 days is now 21, and that surpasses the threshold for high concern. We continue to work to multiply our efforts to get people in skilled nursing facilities vaccinated with the updated booster. Currently, about 50% of residents have been vaccinated with the bivalent booster, but this is obviously not sufficient given that these residents are likely older and medically frail. Next slide. As we see changes in our early alert signals indicating increased transmission, we pay attention to the significant role that emerging variants and subvariants of the virus have had in driving past surges. The most recently available data show that Omicron BA.5 continues to be the dominant subvariant, that's the red bars, yet every week it's accounting for a smaller proportion of our samples. For the week that ended October 22nd, just under 70% of sequenced specimens were BA.5. This is a nearly 20% drop from what we were seeing at the beginning of October. And it's a strong indicator that some of the newly circulating strains may have an advantage to outcompete BA.5. Sublineage BA.4.6 is what we'd been tracking previously for our early alert metric. Since mid-September, this sublineage has made up somewhere between about 4 and 5% of the specimens, and it continues to do so. However, we're not seeing any particular growth advantage since the percent has remained relatively stable for weeks now. However, BQ.1 and BQ.1.1 more than doubled between the weeks ending October 15th and October 22nd, doubled in 1 week. And BF.7, another sublineage, as you remember, of BA.5, also continues to increase in LA County. It now accounts for about 8% of all of our sequenced specimens for the week that ended on October 22nd. And this also is a doubling since the week that ended October 1st. So that was over 3 weeks. The bright pink section at the top of the bar represents BA.5.2.6. You can see very small increase in sequenced specimens. It's just over 1%. This estimate is, this prevalence is low. It doesn't appear to be increasing rapidly so far, but it does have a spike mutation that makes this sublineage more evasive to antibody treatments. Due to the time it takes for specimens to be sequenced and reported to public health, the local data shown on this slide always has like a 2 to 3 week lag. CDC's national data has the same lag, but they're able to calculate predictions of the estimated proportion of each subvariant circulating now. These estimates show that BQ.1 and BQ.1.1 are projected to increase rapidly. CDC predicts that for the week ending November 5th, BQ1 and BQ1.1 combined will now account for 35% of sequenced specimens nationwide. For Region 9, which includes California, CDC predicts that BQ.1 and BQ.1.1 will account for 37% of our sequenced specimens. In contrast, CDC predicts that BF.7 will account for only 9% of specimens nationwide and 8% in our region. Given the rapid rise of BQ.1 and BQ.1.1, many are predicting these strains, which are highly transmissible, are likely to drive an increase in cases this fall and winter. And while part of the reason they outcompete other COVID strains that are circulating is because they're evading some of our prior protections, given that BQ.1, BQ.1.1, and BF.7 are all sublineages of BA.5, this is very likely to indicate that the new bivalent booster is a good match for reducing severe illness and death among people in LA County and the country. Next slide. One reason for the focus on minimizing the impact of possible COVID surge this winter on our healthcare system is because we're already seeing signs of increased spread of influenza and other respiratory illnesses, both of which also create demands on clinics, emergency departments, and hospitals. I'm going to share some of the updates on both influenza and RSV. Flu and respiratory illnesses are tracked differently from COVID-19 because neither require mandatory reporting of cases to public health. So there is no way for us to track individual cases. What we can do is monitor trends in the percentage of specimens testing positive for flu and RSV at clinical laboratories that serve hospitals and healthcare networks across LA County. On this slide, we're showing the trends for the past 4 flu seasons, as well as the start of our current flu season. That's the little short red bar. The calendar year for flu monitoring begins in October, and it runs through September of the following year. On this graph, you see the months along the bottom, and the axis on the left represents the percentage of specimens that tested positive for flu. Looking at this chart, you can see that the flu seasons do not follow one pattern. The yellow line on this chart shows the 2018-2019 flu season. That season started in December. It peaked around late February, with only 17% of specimens testing positive at its peak. However, the flu season that year lasted a long time, decreasing gradually and only abating in late April. In contrast, the 2019 and 2020 flu season, that's on the blue line, very different. The percent of specimens testing positive started rising in November, and it rose sharply, peaking in January at 36%. That year, the season ended rather abruptly, so by early April, there were no more cases. This may have reflected the fact that that was the start of COVID as well, and preventive measures were put in place. It's not possible for us to say yet whether 2022-23, represented by that short red line on the left, will be a long, mild season like 2018-19, or short, severe season like 2019-2020, or somewhere in between. We do know that as of the week that ended October 29th, more than 12% of specimens tested positive for influenza. And then if you look back, you can see in 2019-2020, that's that blue line, and it's the season where we had the next largest percentage of positive cases by this point of the year. There were only 1.8% of cases that were testing positive for influenza. And you can also see we're very close already to the peaks in positivity rates that we saw in 2018 and 19, which was 17%, and 2021 and 2022 at about 15%. So getting vaccinated for flu as soon as possible is definitely a good way to reduce risk during a severe influenza season, and it also helps minimize the spread of flu. You can, of course, get your flu vaccine at hundreds and hundreds of places across the county, and you can get it at the same time you get your bivalent booster. Next slide. RSV is a common respiratory virus. Everybody knows about it now. It's been around for many, many years. It spreads through droplets, and usually it causes mild cold-like symptoms. Many people will recover in 1 to 2 weeks, but it can be more serious for older adults and very young children. The graph set up just like the previous graph, starting in October and ending in September. The most current season of RSV is shown in red at the far left. And you can see that like flu, we started at a much higher level than usual. Currently, 18% of specimens are testing positive for RSV. The current level of positivity surpasses the peak for the last 4 seasons. As with flu, we're not able to predict whether this is now starting to peak or we're starting to see a more severe season that's going to last for a long time. But we do know that RSV activity is unusually high for this time of year, and because of that, it warrants caution. You can see that we've got a slight decline there that could either reflect that we're starting to come down, or more likely it reflects that there are many more people that are getting tested for RSV. So rather than having an actual decline, we just have a difference in the percent because the denominator has changed so dramatically. But I do want to note that in some southern states that saw an increase in RSV cases earlier in the year than California did, they are starting to see declines. So while this small decline that we have here is probably likely an artifact, we will track this carefully over the next 2 weeks to figure out whether or not we've seen our peak and we're starting to come down. Next slide. With these high levels of flu and RSV activity, especially in children, we're keeping a watch on pediatric hospital capacity. This is the 7-day averages for the percentage of pediatric hospital beds occupied from June of 2021 through November 8th of this month. The blue line is the percentage of staffed pediatric ICU beds occupied across LA County. This number tends to be somewhere between 50 and 70%, as you can see. The yellow line is the percentage of all staffed non-surge pediatric beds that are occupied across LA County. As you can see on the graphs, the occupancy percentages did just start to trend upward in recent days, but they're not really that far above the levels we saw earlier this year and last year. The 7-day average for the percentage of non-surge beds occupied is over 60%, and for pediatric ICU beds, it's now at around 70%. And these numbers don't translate into a dire situation at hospitals at this moment, but we are hearing anecdotally that hospitals and healthcare workers are feeling stressed. It's important to note that while this metric is reported as a percentage, many hospitals have only a small number of pediatric beds, meaning that as few as 9 or 10 new hospitalizations can have the potential to put a hospital at capacity for their pediatric patients. When there's a lot of respiratory illness circulating, healthcare workers are also vulnerable to getting sick, and they then need to stay home to care for ill family members. We saw that in the past surges, and we can see that again given the increases in respiratory illness that's circulating. Knowing that we're facing the possibility of having multiple respiratory illnesses circulating all at the same time and stressing our healthcare system, we all can be sure to do the things we know that work to prevent spreading respiratory illness. Washing our hands, wiping down frequently touched surfaces, staying home if we're not feeling well, and wearing a well-fitting high-filtration mask when indoors, especially if you're around those most vulnerable to severe illness, the very young and the very old. Next slide. Facing the potential of a winter with a high level of community risk from respiratory illness, I do want to just share the LA County preparedness table for COVID-19 and provide an update on how we're doing on preparedness activities and readiness to respond to potential surges. We do update this weekly on our website, so feel free to keep tracking us over time. On both this slide and the next, you can see that in general, we're very well prepared as a county to mitigate the impact of COVID, including ensuring good access to vaccines, testing, and therapeutics. Capacity to respond to outbreaks also remains high. One notable area of concern is related to our capacity to sequence specimens to identify new strains of the virus. This past week, the number of positive case specimens sequenced dropped to 294, and that put us in the needs improvement category. The small drop is associated with the fact that there's a lot less PCR testing that's going on, and the sequencing at this point is done from samples from PCR testing and not from antigen testing. We are looking for some new partnerships with some of our larger labs so that we can rapidly increase this number. Next slide. Another area that you could see of significant concern is the very low number of residents 65 or older that received their updated bivalent booster dose. You could see in the far column that this indicator is now classified as yellow for needs improvement. At 23%, it's far below the 60% that we need to meet the threshold for adequate. This low number is worrying, especially given the possibility of a winter surge fueled by new strains of the virus that are very infectious. Those over 65 remain at elevated risk for severe illness from COVID-19. And for many older people, it has been months since their last booster. Next slide. Knowing the low numbers, it's helpful to look at the uptake of the bivalent booster for those 65 and older across the county to best assess how to target our efforts. This slide shows the percentage of people who are 65 and older and receive the bivalent booster by community. The purple areas have the highest bivalent booster uptake. That's somewhere between 28 and 58% of residents. Next, the blue areas represent an uptake rate of 20 to 27%. In the green areas, 16 to 19% of residents have an updated booster. And in the yellow areas, there's only 7 to 15% of people who've received their bivalent booster. Areas with some of the lowest uptake rates include the northern parts of the county, South Central LA, neighborhoods in and around Compton and Watts, and Wilmington. These are also some of the most economically disadvantaged areas in our county, and areas that in past surges had high COVID-19 case rates. And even in areas where the bivalent booster uptake is higher, it's still not high enough. There's no areas where it meets that 60% number that we want to see for preparedness. Next slide. And unfortunately, it isn't just older residents not taking advantage of the bivalent booster. As you can see on this table, only 12% of those eligible for the bivalent booster in LA County have received this dose. The lowest uptake is among the younger age groups. For children 5 to 11 and 12 to 17, bivalent booster rates are 4% and 5% respectively. Next slide. With bivalent booster rates so low, I do want to take a moment to address inaccurate information that we commonly hear about the updated booster. First, many people make the assumption that because they have had a COVID infection or they had their prior vaccines and boosters, that they currently remain fully protected. But every virus is different. Maybe you've heard this said about measles or chicken pox, and the natural line of thought is that this must be true for all viruses. Once I get vaccinated, I'm done. Once I get infected, I'm done. Unfortunately, it's not. For many viruses, including COVID-19 and influenza, protection needs to be regularly updated. This past summer, the New England Journal of Medicine published a study that showed how immunity against COVID-19 wanes over time. The likelihood of getting infected or reinfected for both those who had been infected and those who had been vaccinated increased within 6 months of a prior vaccine or infection. And while immunity against COVID-19 is different for every person based on many variables, including prior vaccination, infection, and the most dominant variants that are circulating at the time of infection, what is consistent is that the immunity decreases over time, not only due to our immune system, but also, in the case of COVID, because the virus changes quickly and new variants can evade prior immunity. Another myth we commonly hear is that it's better to contract COVID-19 to build immunity rather than getting vaccinated. This is a very risky way to go, and there can be possible long-term consequences. The CDC reports that 1 in 13 adults who have been infected with COVID-19 have long COVID symptoms. A recent study in California said it was 1 in 8. This means that more than 3 months after being infected, people are still experiencing symptoms of COVID, symptoms that they didn't have prior to the infection. In addition, if a person contracts COVID-19, there is always the risk of hospitalization and death. While 3/4 of the people who pass away are in fact elderly, that means 25% of the people who pass away are not. One of the most difficult things I have to do is look at the death report each day, knowing that families have lost loved ones. And tragically, your chances of dying from COVID, even if vaccinated, are higher if you aren't boosted compared to those who are boosted. Many people also falsely believe that COVID-19 is over and there's no longer a risk for severe illness. In LA County, our mortality rate remains high, as it does across the county, and we continue to see hospitalizations, as I noted, across all age groups. With the continued emergence of new variants, it's just not possible or accurate to assume that the virus is evolving to be less dangerous. Even if a person contracts Omicron and it feels like a mild infection, there is always the risk of passing it on to another person for whom it will not be a mild infection, especially if you're asymptomatic or if you don't even have symptoms. COVID-19 is still with us, and it's important for us to use all of the tools we have to minimize the impact in our communities. And lastly, many people believe that they're not eligible for the updated bivalent booster, or they're already up to date, and the booster messaging is not directed at them, and it's not reaching them. If you've not had a COVID-19 vaccine or booster since August or before, and you're over 5 years old, the new bivalent booster is available and recommended. It can be administered 2 months after the primary series or your most recent booster, and it is recommended 3 months after a recent infection. Next slide. Just as a reminder, bivalent boosters, as the original series of vaccines, are widely available in LA County, and we have plenty. We can give a booster dose to every single person that's eligible. I know that earlier in the pandemic, vaccines were very precious, and often the mindset was that people at lower risk should wait. But this is not the case anymore. If you're eligible, you can and you should get your updated booster now. People can go to our website, ph.lacounty.gov, how to get vaccinated. You can find options for where to go to get the updated booster. We'll also tell you if there's flu vaccine at the same site. Some sites also offer the monkeypox vaccines, and many sites also will help you get tested. There's over 1,000 sites across LA County where you can access the vaccine. Like the primary series vaccine, updated boosters are free. They don't require a disclosure of your immigration status, and oftentimes you can find a place to go where you can just drop in without an appointment. People 5 years of age and older are all eligible, as long as it's 2 months after their last dose, to get that bivalent booster. If you need your primary series, you can go to that same website. We'll direct you to all the same places where you can get your initial dose. Next slide. And for those who face the greatest risk of severe disease or death from COVID, they may also be the same people who have trouble leaving their home or getting out to their health concerns, their advanced aging, or being reliant on in-home medical equipment. We do want to make sure that everyone has easy access to the updated bivalent booster. So we continue to offer in-home vaccinations and transportation services for all homebound residents to make sure they have the option to stay up to date on their COVID-19 vaccines so that they'll have maximum protection. You can call, these services completely free. You can call us 833-540-0473 for information. We'll answer your questions. You can request an in-home vaccination appointment, or if you want to go to a vaccination site and you need help with transportation, we can do that as well. That call center is open every day from 8 in the morning till 8:30 at night. You also can go on our website, ph.lacounty.gov/vax@home, and there you can fill out a form, and again, we will contact you, make an appointment to come and make sure that you get your vaccines. Agencies, home health aides, loved ones are all welcome to go ahead and order a home visit for someone that they love. In closing, as we head into the holiday season with many opportunities to gather with those we love, it makes sense to do our best to think about layering in the protections that are needed to safeguard the most vulnerable person or people at our gatherings. None of us should be afraid to continue to use mitigation strategies that we know work against many respiratory viruses. This includes wearing a high-quality, well-fitted mask when you're indoors and testing before gathering. Small changes now to our gatherings could mean that we avoid big changes that can become necessary if cases and hospitalizations really surge. And for all of us, given what we've learned about this shape-changing, ever-mutating virus, we'll need to get comfortable with the idea of staying up to date on our COVID vaccines to maximize the protection that's offered by these reformulated doses. And now, happy to take your questions.
Shall I?
You shall.
Okay. Looking at the 12%, so that is 12% of eligible residents have received that bivalent booster.
Yeah.
How much do you think that number is so low because of distrust? What do you think could have been done differently, and what is the department looking to do to improve that?
Yeah, those are great questions. Thanks, Marla. I do want to note that we have, I think, like 400 community health workers, promotoras, that are out going door to door, going to events to try to figure out, what is the disconnect. And I'll be honest, many people, they're reporting to me, 25 to 50% of the people they're talking to have no idea that they're supposed to get another booster dose. And they're confused because they've heard folks say the pandemic is over, that if you were already boosted, that counts. So I do think it's complicated. because we're asking people to get another dose. For some people, this is the 5th dose. For some people, it might even be the 6th dose. And that's unusual, even with vaccines where we ask people to come back multiple times. Especially because we weren't able at the beginning to say, you know, this is a vaccine you're going to need to take over and over and over again. So I feel like there is a lot of confusion, and we haven't done a good job sorting through those confusions. I think, you know, we're back to an all-out effort, sorry, both to promote easy access to vaccines, but also to partner with our community partners, our faith-based organizations, our event venues, to just again make it clear it's really, really important that people get the updated booster.
Your bottom line message, because I think you did hit on it, that in the beginning, there literally was no way for public health officials to say you need this 3 times a year, for instance. Is that what you're saying?
Yeah, I mean, there was no way to know. I mean, I'm not an expert in this area, but I would venture to say that we have never seen a virus that spreads so rapidly, that mutates so much and so quickly. I mean, we'd have to, you know, I'd have to go to the infectious disease team and just verify. But in my history, the time I've been alive, I don't know of any virus that has mutated like this, and mutated significantly enough that we're constantly having to look at how to update the protections. So I don't think we could have predicted that. Even knowing that coronaviruses are different than other kinds of viruses, I think we're all a little bit shocked at how rapidly these mutations are happening and how much spread there continues to be. All the more reason to be grateful that we actually do have vaccines that continue to work as long as we get updated doses. And I think we're optimistic that, you know, perhaps we do get to the place very soon where really we are looking at getting vaccinated similar to flu once a year to get an updated level of protection.
Those sublineages that you mentioned, it seems like the big concern are the sublineages of BA.5, right?
Yeah, they're all sublineages of BA.5
Okay.
right now.
So those 17% or so in LA County?
As of 3 weeks ago.
Okay, so.
I think the predictions from the modeling are probably more accurate, that we're probably up already to like 35, 38% of what's circulating might now be BQ.1, BQ.1.1.
And I think we all, the big question is, does this produce more severe illness than BA.5?
Right. That's right. And, you know, as always, we can't answer that until we've had it circulating for a while, because there's always a slight delay between the time people get infected and we start seeing big increases in hospitalizations. I mean, it's a great question, Marlon. It gives me an opportunity to just remind all of us that another way to protect yourself if you do get infected, because many people will get infected, is to go ahead and quickly talk to your provider about accessing therapeutics. Most adults will meet the criteria to get like a Paxlovid oral viral treatment, and they should take it. Because again, emerging evidence, because these are relatively newer medications, is showing that it really protects against a severe illness. It also seems to perhaps shorten the amount of time you stay infected. And I think for some people, they've been able to actually, you know, not experience long COVID symptoms as well. So again, emerging science on that. But everything looks positive, and again, there's another way to prevent a lot of people who do end up being infected from getting into the, you know, and needing to be hospitalized. And we didn't have that, 18 months ago either. So we ought to be able to do a better job this time around, as long as people take advantage of the tools that are available.
18% of specimens right now testing positive for RSV. I noticed a slight decline.
Very small decline.
Average age?
Yeah, I would have to look at that because you know that RSV affects adults as well as children. We're tracking a lot of children because particularly very young children can get severely ill, And we've really been urging families to not wait or delay getting care for children who are very ill, given that we know we have a lot of RSV circulating. But we
also
can.
we're better off than Orange County, because I know we have.
Yes, we're better off because we have more pediatric hospital capacity to start with. But as I noted, you know, you get 10 patients, 10 new pediatric patients at one hospital, even if we're at like 75, 80% filled beds, or we have 25% open capacity, that doesn't necessarily translate to hundreds of beds. So we have to be careful, and we have to try to protect ourselves, and particularly very, very young children and very, very old people from RSV. They can really, they can get really sick very quickly.
Is it a requirement to have masks on in this building?
No, it is not.
It is not. So
No.
it is your choice?
Yeah, for everybody who works here. You can wear a mask or you cannot wear a mask. There's no requirement. And I think all the signage has been updated to just indicate, you know, it's a good safety measure. But again, it's individual preference in our building as well.
Okay, I was under the impression that it was
No,
required here.
it's
Okay.
not required.
So, I mean, do you feel that?
I mean, I want to say it's not required in this building. Next door, it's a clinic, so it is required because it's a healthcare facility. These are administrative offices, so it's not required. I don't want people to get mixed up. There are places, all healthcare facilities, where it is required, including our building next door.
So you choose to wear a mask here.
Oh, yeah.
There's
I
four
know.
people.
We all wear a mask.
There's 4 people here.
Yeah.
So what do you say to people who see this, knowing that there's literally, is this more for, let me start over.
Yeah.
Is this more for optics for you?
Oh, no. No, I'm an older person. I don't want to get sick. And I feel very comfortable when I'm indoors keeping a mask on when I'm around other people. I also see this data. There's, you know, it's not even just RSV and influenza. There's other respiratory illnesses at this point in time. We particularly, I think, in this building, cannot afford to have a lot of people go out sick. And we just don't have a deep enough bench to have outbreaks here. So I think while there's no rules here, people are free to make their own choice. I think people are very aware that we neither want to get sick ourselves, nor do we want to, you know, have an outbreak in our small offices. So yeah, I mean, people are just super careful here.
Okay, and so then, with that said, then you're comfortable when you're at community events without
Yeah.
a mask on?
When I'm
Or
out,
indoors?
when I'm outdoors, I'm very comfortable not wearing a mask. When I'm indoors, mostly you see me with a mask unless I'm actively eating or drinking. But I'm very comfortable being indoors with other people who are not masked. At this point, the transmission is still not high enough for me to, you know, really feel super nervous. I know these masks. Mine fits well. It's a respirator mask. I know it gives me a lot of protection. And that's what matters to me. So you will see me at lots of events indoors where many people are not wearing a mask, and I'm perfectly comfortable with that, as I would be here.
And you yourself without a mask, too?
No, I'm almost never indoors without a mask. I think occasionally I'm eating or drinking and I'm without a mask, but in general, no, I keep my mask on when there's lots and lots of people. So if I'm at a big event indoors, my mask is on. I will say the exception to that is there are some events we go to where everyone has to test prior to entering an event, in which case I feel much more comfortable not wearing a mask indoors. Everyone has to test negative.
Sent in. Do you have any more?
No, and
Yeah.
I was specifically
Yeah.
referring to, I know you were at an event in Boston,
Oh, yeah.
and then also for a nonprofit event locally here.
Yeah. For a nonprofit event, I think I had my mask on, unless I was eating or drinking. I mean, I'm pretty careful. I was a speaker at an event in Boston, and I had my mask off when I was speaking. But otherwise, yeah, I'm pretty careful.
You with a mask on.
I
So
know.
when I see a picture without a mask on.
Well, I think, you know, I was at a reception there where we were eating and drinking, so I didn't have a mask on for that. But in general, most people see me with a mask.
I have a question from Jackie Fortier from KPCC, and then I'll go to Ron, send in some questions as well. This is from Jackie. I've talked to numerous people who have contracted COVID recently, and doctors are giving them different advice. Some patients are told they have immunity for 3 months, others 6 months. Do we know how long natural immunity can last, given the swift changes in dominant variants?
We don't. I think there are good estimates out there, and the range is somewhere between 3 and 6 months. You know, I cited a recent study that sort of looked at waning immunity, and, you know, within 3 or 4 months, it looked like it started to wane, and then at 6 months, you could actually measure it pretty significantly. The advice from CDC is to wait, that you can wait 3 months after an infection of COVID before you go ahead and get a bivalent booster, because people feel pretty comfortable that you have some protection for those first 3 months. But I don't think there's definitive studies because we have so many new variants. So it's, by the time we get a study done, there's a new variant circulating. That makes it super hard to figure out what the impact is then going to be. So we start all over.
And then several questions from Ron Lin from the LA Times. What percentage of coronavirus positive hospitalizations are there being treated for COVID versus incidental?
Let me just answer.
Sure.
Let me just go one at a time. So we're still at about the same ratio. I checked a couple of weeks ago, Rhonda. I didn't check today, but it's still about 60% of the people who are hospitalized with a with a COVID positive test are there for some other reason, which leaves us somewhere between around 40%. It's usually between 38 and 42% of the people who are hospitalized are there because they're sick with a COVID-associated illness that's requiring that hospitalization. That number has not really changed, even with the differences that we've seen over, since January, I want to say, or February, even with the differences in the strains that are circulating.
Second question is, are you still planning for a mask mandate for public transportation in airports? Should the case rate exceed 100 cases a week for every 100,000 residents and remain there for 2 weeks?
I don't think that we are going back to issuing mandates on masking for any sector except those that are already, where there's already a mandate that's really a state mandate or a federal mandate, unless we go back into a high transmission category. But I'll take a look at our plan to just verify that, Rhonda, and we'll get back to you. I think what we are assuming is that once we go over that 100 case rate number, 100 new cases per 100,000 residents, we will be strongly recommending that people mask up indoors. We already recommend that people actually, given how easy it is for there to be transmission on our mass transit system and sort of the high rates of illness that many transit workers have experienced, we do suggest that people keep their masks on there right now.
And the last question from Ron is, if people can't get the booster by today, will they not be fully protected by Thanksgiving?
Well, that's a great question, because Thanksgiving is 2 weeks away. So I want to be clear, maximize your protection and get vaccinated today if you're planning on having as much protection as you can from the vaccines by Thanksgiving. But please, anytime now, between now and Thanksgiving, that you find the time and are able to get vaccinated is going to help you and add protection. Thank you.
Anything else, Mark? Okay.
Thank you.
Thank you.
Thank you.
Thanks very much.